I'm absolutely glad to go ahead and have you join us today for what's going to be first of a ongoing series around incorporating 988 as part of California's crisis continuum of care. Today, we're very lucky to have Dr. John Draper of Behavioral Health Link. Dr. Draper has been instrumental in moving America toward that three-digit 988 number. And what we're going to do today is really kind of have a discussion about how we got where we are.
Currently the president of research and development for Behavioral Health Link, which many of you know established the first statewide crisis care coordination system, kind of care traffic control system in the country. And prior to that, I left Vibrant Emotional Health in September of 2022, where previously I had been for 18 years operating as a founding and former director now of the National Suicide Prevention Lifeline and 988. And prior to that, was working for them, providing New York City's 24/7 crisis information referral line, the very first one established in New York City in 1996. And before that, worked on a mobile crisis team, which you'll hear a little bit about shortly. A statement that was made by a close friend and colleague at SAMHSA, Dr. Richard McKeon. Many of you know him as he was the chief of the suicide prevention branch at SAMHSA. He's now at the 988 office as special advisor. And you can see why. He was the guy that wrote the report to the FCC about the three-digit number. One of the things that he noted in there that was really important was this, he believed, is going to be transforming our nation's psychiatric emergency and crisis care system, much in the way that 911 has done for the nation's emergency medical system. I'm going to argue that it's going to go beyond that, actually. I think it's going to transform our behavioral health system, and I think it's going to perhaps even play a significant role in transforming the way we see and accept mental health care in this country. So the reason for it is because the way we've been doing things for so long has been kind of wrong. We've been taking a public safety approach instead of a public health approach to behavioral health crisis care in this country. Essentially, this has been something that has been criminal, in fact, in some respects. One could argue that when a person is in behavioral health crisis, serious mental illness, and is a harm to others, there is perhaps a public safety approach need that can really be, I think, persuasively argued that there is a community need to make sure that we are safe under those circumstances, and there are laws in both civil and criminal courts for people who are threatening harm to others or are harming others. So there are laws about that, but there have been laws also about harm to oneself. We can look back on it now and say it's repugnant, but you can see back in the 60s, there are 32 states that had laws against suicide and suicide attempts. I'm not really sure how one would enforce a law for somebody who kills themselves, perhaps a afterlife in prison. But there is, again, if you look at from the 1960s, it took until the 1990s for us to remove all laws off the books for suicide and suicide attempts. And this idea of taking this public safety approach really started with, I think, a lot of fear, even terror, about how we were going to deal with mental health and suicide-related issues in this country, because we didn't really know how to care for it. We didn't know how to treat it, and when people are not receiving help, we feel helpless to manage it. So, what do we do? And what we've been doing for all through last century, certainly still to this day, but prominently in the 19th and 20th centuries, is use involuntary commitment, put people away essentially that we couldn't help. And if we didn't help them, we felt something bad was going to happen to them or others. It certainly, as noted before, there was an argument for police power and that underpinned involuntary commitment procedures that, yeah, if somebody is really, really ill, perhaps this is going to compromise the welfare of others. So maybe it is a public safety issue. And if they can't take care of themselves, maybe something bad is going to happen to them, and I don't know how to take care of them. So the state is going to have to act as their parents, and the parents patriae notion in legal principles underlying involuntary commitment. So after many years of this, all through the 18th century and 19th century up until the 50s, when Thorazine was created and became seen as some way to address persons with serious mental illness that had some degree of efficacy. And of course, the advocates who were righteously banging their fists saying, have you been to the asylums? These are not places where people are getting cared. They're just cared for. They're snake pits. And in many cases, they were abominable treatment conditions, which were entirely inhumane and not a way to actually show caring for people who were supposedly being cared for. So then you have this need to take them out of the hospitals. And this deinstitutionalization process was really something that was enacted through a law Congress passed and signed by President Kennedy in 1963 to shift care from these abominable institutions to the Community Mental Health Centers Act, and very well intentioned, a huge milestone for community mental health, but not an immediate panacea to the problem. In 1964, the next year, there was also a desire to reduce to enhance deinstitutionalization, getting people out of the hospitals by making it harder to get them in. So it wasn't the same standard of involuntary commitment as there was before. Before, all you had to show is that a person's mental impairment left them gravely disabled, and so they had to have the state be their parents and take care of them. But now you not only had to show that they were seriously mentally ill and had functional compromises, but that they also were a danger to self or others. Now you put all that together with the fact that just by passing a Community Mental Health Centers Act does not make community health centers suddenly appear out of nowhere, that it was going to be quite a long time. And even to this day, we still don't have sufficient mental health care in our communities, but certainly not in the 60s. So you had a number of people who were coming into the communities from the hospitals who had nowhere to go except their homes and in their communities, who were suffering, their families were suffering. And what did the families have to do to try to get them help? Maybe get them back in the hospital. And how do you show them, how do you get them back into the hospital? Well, you have to show that they're a danger to self or others. So there was a pressure in the culture to really demonstrate dangerousness. And then you had, of course, 911, which was created in 1968, which was the easiest way, perhaps, to get help in the community and justify that this individual who is suffering in the community is also a danger to self or others. Call the cops. Now, I'll fast forward to today and in California, and you'll see the impact of this public safety approach with 911. The impact on 911 specifically is that about 20% of the calls in Los Angeles County alone, about 50,000 annually in LA County, are related to behavioral health crises. Overall, nationally, about 15 to 24 million of those calls could be, let's say, sent to 988 theoretically. Over time, we hope that's what could happen. But right now, it's still about public safety, and hopefully we'll be shifting with 988. How is the public safety approach working in terms of keeping people safe? Well, the effects of psychiatric hospitalization are not demonstrating uh, basically outcomes that we are encouraged by. We could say that people are safe for a time while they're in the hospital. Possibly, we do see a relatively high suicide rates of individuals in hospitals, but we certainly know that upon discharge, there's a 44 times higher rate of suicide for people who've been admitted for suicidality. So if it's helping, I mean, who knows, maybe it'd be 88 times if they weren't in the hospital. But we do know that hospitalization is not in the long term making a significant difference in terms of keeping the suicide rate down. Uh, Discrimination is real. This we absolutely know, seen, and are documenting. Blacks, for example, are significantly more likely to be committed than whites, and they're also more likely to be diagnosed as having schizophrenia. They're more likely to be referred to as exhibiting dangerous behavior. They don't have as much access to quality community care, and they're more likely to be taken to the ER via police escort. That doesn't sound like a system that's either equitable or effective. Persons who have mental illness will also tell you that the impact of having police visit them is not really what we would call the appropriate approach. Perhaps from a public safety approach, I don't know. Take a look at this. 31% of the persons in California jails in 2019 have a mental illness. If we think the public safety approach is effective, are the jails the right place for them? Well, about 26% of them are on psychotropic medications. So we've pretty much exchanged what was once happening in the institutions that we've tried to take them out of, now that is happening in the jails. And they're 3.5 more likely to die by suicide in jails than the general population is, due mostly because of there's more persons with mental illness in jails. And with persons who are untreated with their mental illness, they're 16 times more likely to be killed in police encounters. So for example, in Los Angeles in 2021, more than half of the 37 police shootings involved individuals in mental health crisis. The public safety approach doesn't seem to be one that's working. In fact, one could argue very persuasively that it's actually harming in so many places the people that it's designed to supposedly be caring for. So instead, maybe we should send them to mental health professionals. If you're talking about suicide and suicide prevention, many mental health professionals are going to say, don't ask me. I am not ready for this. The New York State survey of several mental health providers in 2014 noted that most of them have not had suicide prevention training. The National Action Alliance for Suicide Prevention did a survey in 2013, found that about half didn't have enough skills, training, or supports to work with suicidal persons. And what we have seen up until very recently, and maybe still happening, that most of the clinics, therapists that you call various times, and it's after hours, they'll have a little recording that will say, if you're having a psychiatric emergency, hang up and call 911. Hopefully, we're changing the recordings to 988 sooner rather than later. So what's it look like in the 21st century in the prospects for perhaps a public health approach? Now, some of the public health approach, the seeds of it have been planted last century, but you're about to see that most of what's happening in terms of the switch and the shift from public safety to public health is really occurring this century. But the seeds of it were at least thought about at the beginning of last century. This is Clifford Beers. Many of you know him as the founding father of mental health advocacy and what is now called Mental Health America here in the United States. He tried to kill himself by jumping off a roof in college around the turn of the 20th century, and went to a hospital and was there for a couple of years. And he came out of there saying that is no place for anyone, not only to get better, but no place for anyone, period. And so he began his advocacy career as a person with lived experience, saying that is no experience that anybody should have to live through. But what he did say is that there's probably other ways in which we should and could be dealing with people who are suicidal. And he said this explicitly. as you can see here, he really thinks that, boy, if we had some way to get help immediately, maybe we could save a lot of lives. Now, at the turn of the century back then, yeah, they had telephones. Maybe they could have started a crisis hotline. But it was many years, in fact, about 50 years later, when the very first crisis hotline was established, but not in the United States. This happened in UK. There's an interesting story about how the Samaritans UK started. Vicar Chad Vera read in a London newspaper about a 13-year-old girl who, when she began menstruating, believed that she had syphilis. She went into a panic and she killed herself. And this horrific, abominable situation, as Vicar Chad Vera saw it, could and should have been prevented. It was just a matter of having her feel safe enough to talk to somebody about what was going on. And of course, they would have told her this is totally normal. So he said, I've got to do something. And there's a lot of people like her who are suffering, and I need to give them some kind of confession booth, a place that they can come to and get help, even though they feel like they're overwhelmed with shame. So I'm going to have them all come to my office. And so he sent word through the streets, through networks, and in the newspaper, said, come see me at the church, and I can talk with you if you're suffering and you're feeling hopeless. A lot of people did come. They stood in lines outside his office. And by the time they got into his office, most of them said, you know what? I'm doing pretty good. I don't really need to see you. And he said, well, why? What happened? So, well, you know, the nice ladies, there were volunteers out there who gave me a cup of tea and talked with me and listened to me and heard what I had to say. I just feel better now. And Vicar Vera thought, maybe I don't have to be the person who's going to take care of everybody. Maybe it's people who are caring, who can show caring, who have the human touch, who have empathy, who can listen and be present and befriend an individual, can make that difference. And so he said, let's use volunteers, and not only use volunteers, but if we gave them a phone, they could be anonymous and contact us as if it were a confession booth. And so the UK Samaritans was born in 1953. It's now the most popular model of crisis care on the phone in nations across the world. Samaritans, the befrienders, is huge internationally. Here in the United States, in fact, in California, is where we saw the very first crisis hotline established. And it started as the LA Suicide Prevention Center had acquired a grant from the National Institute of Mental Health in 1958, the father of suicide prevention and suicidology, the study of suicide. Ed Schneidman, Norm Farborough, Bob Littman, came together to apply for this grant. And essentially what they really wanted to do was a lot of research with this grant and train local professionals that wanted to treat suicide in their community mental health center and do some community outreach and education. They didn't initially set out to have a hotline. They basically, when they closed at night, they had some folks who were calling and at night, and they heard that a lot of people were phoning. And they said, well, maybe we should have some people late at night who after hours can take some of these calls, because we're called the Suicide Prevention Center. And a lot of people think we're here to prevent suicide, and it's after hours that they're thinking about suicide. So that led them, basically by demand from the public, it wasn't something they conceived of, that we should do something like set up a hotline, much like UK Samaritans. In this case, they also began to use volunteers. They supercharged this hotline and made it 24/7 after Marilyn Monroe killed herself in 1963. And also in 1962, another California center, the San Francisco Suicide Prevention Center, started up, and it started up entirely intentionally as a hotline. And it was really the brainchild of Bernard Mays, who was a gay clergyman, incredibly charismatic, very much a non-traditionalist, and thought Under no circumstances should we be going into the mental health care system if we're in crisis. And by we, I mean people like me, people who are gay and who are going to be judged, and who in many cases, people are saying what I'm doing is illegal. How am I going to feel safe to talk about how I'm feeling in a culture that has marginalized me? And so he said, what we need is this anonymous ear. And so he began to send around flyers around the city among homeless and persons who are LGBTQ. And this basically PR message was, thinking of ending it all, call Bruce. And Bruce was kind of the name given to everybody who would answer the phone. And at first it was him answering that phone. He went on to start NPR later. Bernard Mays was an amazing man and did some amazing things at the San Francisco Suicide Prevention Center. But essentially what you're seeing is that this is coming out of churches, it's coming out of clergymen, and it's also coming out of academic institutions where there was a lot of drugs and alcohol in the 60s. And there was a lot of laws and a lot of judgment and a lot of police power that was saying, if you talk about any of this, we're going to take you to a hospital or we're going to arrest you. So there needed to be some safe, anonymous way to get care. And so from the grassroots level, at academic institutions, in churches or out of churches, grew crisis hotlines as this kind of non-traditional alternative to the mental health system where people could get care anonymously. And of course, suicide at that time, as you remember, it was still a crime. So again, this was an alternative to the traditional mental health care that was being promoted as the place to go for people with mental health problems. Mobile crisis teams also began to flourish a little bit around this time, especially in the 70s and 80s. We started to see them grow. And we do know that mobile crisis teams, as an alternative to emergency response vehicles, including police, are much more effective in terms of getting people linked to care. We know that sending a cop to have somebody involuntarily committed is not a great introduction to the mental health care system and can alienate people. Mobile crisis teams are much more effective at reducing unnecessary hospitalizations, linking people after discharge, and making sure that people are feeling safe in the community. This is also where I became introduced to crisis care. I started off as just wanting to be a psychologist, a therapist, figured I would be an outpatient therapist, and eventually have my own private practice. That's really all I wanted to do. But I needed to get a job after I finished my internship in New York City, and the best paying job happened to be this mobile crisis team at Interfaith Medical Center in Brooklyn. So I set about going into homes all over Brooklyn to help people who were with serious mental health problems, who are unwilling or unable to get care on their own. And a light bulb went off in my head the very first time I walked into someone's home, and I thought, this is the way we should be helping people. We should be going into their lives where they're experiencing their crisis, talking with their families, talking with them in their homes. I mean, just imagine doing an assessment with a person where they live, with the people that know them, present, caring about them, seeing how they live, looking at how they decorate or don't, and how they're caring for themselves or not. All of that is evident. And they're also safe. It's their office that you're in, not yours. And so they're in control. And if they're in control and feeling safe, they're going to be more likely to tell you what's going on, and you're more likely to be able to see what's going on. So for those of us who are trying to do a complete assessment about how someone's doing, you're going to get a very complete picture that you're not going to get for maybe 6 months or ever in an office. And they're more likely to, if you intervene with them and help them in their home, that intervention is more likely to stick than when they leave your office and go back to where the troubles are. So this to me was a revelation. And I said, this is what we need to start spreading as gospel. There was a lot of other gospel spreading in the late 90s. And a lot of it was really coming from people who said, we've got to do something about these lingering laws and stigma around suicides because it's actually killing people. And if we can actually, as survivors of people who've died by suicide, bring their voice to the fore and say, there's something we can all do to keep people like my son, my daughter, my husband, my wife, my grandparents, my parents, something we could do to keep them alive. Let's do it. And those voices were instrumental in the Surgeon General's call to action preventing suicide in 1999. Surgeon General David Satcher was very inspired by happenings at the famous Reno Conference of Suicide Prevention Survivors. So that was really spearheaded by the Suicide Prevention Action Network back in like 1996. And the voice of Senator Gordon Smith in the early 2000s, the voice of the Ombig family, all of those had a huge impact on changing and changing the way we think about suicide and suicide prevention at the government level, and creating funds and opportunities for us nationally to change the direction from focusing on suicide to suicide prevention. The big change really, I think, started with SAMHSA funding national crisis lines. Here was the authority, the national authority on substance abuse and mental health services, saying, you know, this non-traditional care that people are getting on crisis lines, let's bring them into the fold and find out if people are actually helped by it. And if they are, let's see if we can make it more scalable, because that's the only way we're going to be able to reach people who are less willing and able to get care traditionally in the system. So SAMHSA embraced crisis hotlines in 2001, as did Congress, and they began funding what first started out to be the Hope Line and 800 Suicide, then morphed into the National Suicide Prevention Lifeline after I joined in the Mental Health Association of New York City, now Vibrant Emotional Health, became the administrators of the national network. And then there's all these other services followed, as you can see, the Spanish line, Veterans Crisis Line, chat, text, and disaster distress helpline followed. What happened after we started and then eventually evolved over time, this was kind of the way things came to us after, or actually came to 988, just before we launched 988. We had about 200 centers that we had brought together and helped certify and provide best practices to. Those 200 centers were also had national backup services. We had 25 crisis chat and text centers, 4 Spanish centers, a veterans crisis line backup, and again, chat and text services that were not as significant pre-988 as they are now. I won't go into the operations and infrastructure. I can talk more about that in the next outing next Friday. But just to note, this is the way it looked just before 988. But what's really important, I think, that happened with SAMHSA was that by SAMHSA not only embracing crisis hotlines by funding this administration to scale up this kind of national portal for local services, but to actually provide evaluations to see whether they worked, and if they did work, what did work, and how we could make them better. And this was such a joy for me when I first began administering the line in 2004 to know, and actually the crisis hotline that I had started in New York City was one of the first that was evaluated in the seminal findings from doctors Madeline Gould and John Califat. And those research findings or evaluations were really setting out to do 2 things. look at what processes might be effective and to whatever degree counselors were following those practices in the way that they were trained to do. And secondly, were there good outcomes? Was it actually reducing distress and suicidality? And those findings, which the evaluations began in 2002 with those 8 centers, including ours, those findings were published in 2007, but they became available to me and our committees of advisors that I had formed to help us determine how to translate what we're learning from these evaluations to best practices. This was an iterative process that goes on to this day, where we do evaluations, we identify the best practices from the evaluations. We then say, okay, from those, this is the standards that we should establish, and let's implement those. Let's do training and TA around those, and then evaluate them again. And then if there's still needs for improvement, let's identify what needs to happen, and then we continue the process in the cycle of iteration. This has led to quite a number of policies and standards over time. The National Suicide Risk Assessment Standards in 2007. Thomas Joyner, one of a world famous suicidologist, was our subcommittee chair. We had a number of wonderful national experts that worked with us on the National Suicide Risk Assessment Standards, which to me are still the seminal ways of thinking about assessment. But what we also learned over time is that we need to get away from just thinking about risk assessment. We really need to be thinking about safety assessment, because risk is not something we can accurately predict, and is more often used in practice to protect the provider from liability fears than it is from actually focusing on what it's about, and that is enhancing the person's safety. And frankly, we're a lot better, and the research has shown that we're a lot better at helping people be safe than we are at predicting whether people are not going to be safe. So focusing on how we can assess people's level of safety, indeed risk, but how that translates to a plan of action is really important. So in 2019, we changed it to the safety assessment standards and upgraded that, as we've also upgraded the national policy for helping callers at imminent risk of suicide. This became the first national policy that was ever established for giving people guidance on what to do when somebody says, I want to kill myself. The evaluations really did show overall that what we were doing worked, and that this was not only very reassuring, but also very enlightening. Some of the things that we did learn is that it did in fact reduce emotional distress and suicidality by the end of the call. A RAND study that was actually done on some centers here in California determined that the crisis centers that were using the standards that were established by the Lifeline were better at assessing and reducing distress in callers than those who were not part of the Lifeline. We also found that our guidelines for imminent risk were making a difference. In fact, what we were trying to do was reduce the amount of time that we are going to be calling 911. We really wanted to make sure that callers' collaboration, and we were reducing invasive means of intervening with people. We really wanted to reduce coercion wherever possible, because we wanted to introduce people to the system and really send the message that this is about your safety. So collaborating with them was able to occur in about 75% of the people who are even at the highest risk. So our standards and trainings were really making a difference in reducing imminent risk, or at least helping people collaborate to keep themselves safe. 2/3 of the people that were using our chat services reported less distress, and 50% of them less suicidal. The follow-up calls have really been were I think particularly illuminating in terms of learning what they could do. I mean, so many times we think about just the call, but it's really what happens and can happen after the call that can make a difference. And those follow-up calls and the people who consented to them said that this really made a difference in keeping them safe. About 80% of them said it made a difference. And in fact, about half of them said it's the reason that they were alive. In Georgia, another thing that we learned, and this was well before I joined Behavioral Health Link, I was always an admirer of what Behavioral Health Link was doing, the Georgia Crisis and Access Line, and some of this data was really eye-opening. The U.S. first statewide crisis center, as I mentioned, was established there, and what they found, and what kind of justified that statewide evolution was locally, when they had a few counties that were getting mobile crisis teams and others that were not, they compared the outcomes between those two, and the ones that had mobile crisis teams had 5 times fewer encounters with law enforcement than the counties that didn't have that. So this, of course, spurred Georgia to say, we need to be dispatching and establishing mobile crisis services all over Georgia. And that's what really led to the statewide model. And they found that they, or at least estimated, about a $70 million savings by diverting callers from unnecessary ER and hospital visits, and that they could reduce the wait time and intake time by 60%. In Arizona, something similar also was found, where the crisis stabilization services, they had the full complement of the crisis care continuum there. Both the Georgia model and the Arizona model very much underpinned the Crisis Now model and the national guidelines for behavioral health crisis care. And it was this kind of data that really convinced people that this is really the way to go. Police could drop off folks at the crisis stabilization units, and they did. About 23,000 people were dropped off in crisis care, crisis stabilization, meaning that they didn't have to hang out in the emergency department forever. The people, everybody was accepted. They could just drop them off there for about 2 minutes and then turn around and get back to work and, fighting crime, so to speak, and not having to be working in the mental health care system. This saved about 37 police hours, 37 full-time equivalents in police hours, which is a significant savings for one county, considering what the police officers could be doing that's not having anything to do with behavioral health crisis. Client wait time was reduced by 45 years total. And you can see here some of the other data that's in terms of the cost savings that were significant. All of this information, what makes crisis care effective, it could save lives and save money, made a huge difference in establishing the National Suicide Hotline Improvement Act of 2018. At that time, Senator Orrin Hatch and Senator Stewart, or House of Representatives, Representative Stewart from Utah said, we should introduce this National Suicide Hotline Improvement Act, which essentially was going to investigate whether a 3-digit hotline number would make a difference. And would it be more effective? What number might that 3-digit number be? Might it be like 211, 311, 411, perhaps 611, the one that wasn't fully assigned yet? And what's the cost benefit analysis? Should the government pay for this? And if so, is it worth it? SAMHSA made the recommendations to the FCC as a result of the National Hotline Improvement Act. And they said, yeah, it's going to be easier to remember if we use this 3-digit number. They also said, because the Lifeline is effective, we've seen it work, then by scaling it up and making it more accessible to people, we're going to save more lives. And it's also going to divert more unnecessary calls from 911, law enforcement, and emergency services. And they believe, as noted earlier, Dr. Richard McKeon, that it could transform crisis care systems nationally. To me, one of my favorite advisors is my daughter. At that time, when we had the 3-digit number come up, I said to my daughter, who's had her own mental health issues over the years, and she was 18, and of course, at 18, you know everything. And at my peril, I wouldn't ask her. She would say, Dad, why didn't you ask me? So I asked her, what do you think about this 3-digit number? And this is what she said. She said, Dad, I think it's going to do more than anything that we could possibly do to eliminate stigma against mental illness in this country. And I said, well, why is that? And she said, well, if we had a 3-digit number like we have for medical emergencies, if we had them for psychiatric emergencies, people would know that they're real and that they require a very different response than somebody in a police uniform showing up at your home. And I said, that's exactly right. So that really, was among the many things that I thought was an incredibly powerful argument, is that could really reduce stigma by switching from a public safety approach to a public health approach. And that's also what Chairman Pai said from the FCC. And he said this 3-digit number is going to save lives and it will save money. And if we're going to do a cost benefit analysis, lives saved, money, all of that will make a difference because we know these services work. And again, the evaluations that SAMHSA had invested in came home to roost. And that is why 988 essentially is happening, is because SAMHSA had put these evaluations forward and they continued to show the effectiveness of the hotline. So since then, since 988 was established, not yet launched in 2020, there was a lot of news reporting that, hey, they passed this, it's going to be enacted in 2022. And in that law that was passed, they said we need to have a report on what the infrastructure should look like from SAMHSA. We need to get a report on how we can access help to high-risk populations like LGBTQ populations. We got to figure out this geolocation issue because calls are routed from this national routing system by area code, and a lot of people don't live where their phone area code is anymore. And then finally, there's this really exciting opportunity, and that is that states are going to be allowed to levy a fee on wireless bills. Oops. States are allowed to levy a fee for local 988 services on their wireless bills. And this is the way 911 is being funded currently. So it doesn't mandate states to do it. They can elect to do it whether they want to do it or not. So right now, 50 cents to $1 of your cell phone is paying for 911. So might something similar be used for your monthly cell phone bills to enhance 988 crisis care? 988 is clearly different from 911. 911, when you call 911, it goes straight to the local 911 center. 988, it goes to a national routing system. It's operated by Vibrant Emotional Health in Entrado, and then they route by area code. But I think a huge difference between 988 and 911 is that the call is the intervention. The text is the intervention. The chat is the intervention. And that 911 really looks to dispatch. That is secondary. If we can reduce, if we can basically de-escalate the crisis over the phone, that's what we're trying to do. And also can link to outreach services and care, and really trying to focus on the least restrictive intervention. That is not what 911 is about. There's a lot of things that the Lifeline is intending to do in terms of scale, scope, enhance equity of access, making sure that there's call, chat, and text services, as well as follow-up capabilities, making sure that there's specialized services for populations that have historically been marginalized, less likely to reach out for care. So we need to have services that help build trust and reach into those communities to help those individuals feel safe to get care. And also we need to do something about getting stakeholders to invest more in these services. And if we can do that, we can have a full continuum of care, which is really what 988 is desiring to do. And under these circumstances, whether it's the phone, which can resolve the crisis about 80% of the time, and then there's 20% of the times where it can't, we ought to be able to send out mobile crisis teams where 75% they can resolve the issue in the field. And if they need to go somewhere, perhaps it should be other than an emergency department, to crisis receiving facilities that are much more supportive, less restrictive. And in these cases, when we have those services, about 65% of the time, they're discharged back to the community. And if we have wraparound services that can support them when they go back home, 85% can remain stable in a community-based care. All of this will keep people out of hospitals, out of emergency departments, and out of jails. We do expect that the 988 is going to have huge increases in calls over time. Over the last year, we haven't seen a huge increase. We've seen a significant increase. I think it was somewhere in the neighborhood of 25%, but it hasn't really yet become a campaign, and it's about to become one. There's funding that's on its way that will be going out, and we'll see a campaign that's going to continue this year and next year and the following years that will be promoting 988. And when that happens, we could expect anywhere from a twofold increase to a threefold increase in contacts. Over 5 years, it could be as many as 24 million, an eightfold increase than what we saw pre-988. And we did have a lot of problems answering calls, texts, and chats prior to 988 because we just didn't have enough funding to support these services. So it was crucial that there become funding to support them. So not only was the Designation Act important to help us all begin to prepare, but there needed to be funding behind it. Vibrant Emotional Health, when I was there, we gave grant awards to all the states. About 48 of them took us up on the offer and said that they would use this to plan for their 988 implementation. These 988 implementation grants or planning grants really made a big difference in preparing them for what became a huge funding opportunity from SAMHSA later in 2022, when about $282 million in grants were provided to both Vibrant and the states to get ready for 2022 and the July launch. Now, since the launch, just to give you a sense, things have gotten a lot better because that funding has really made a difference. About December of 2021, about 24% of the chats were answered. 24%, a lot of suicidal individuals, especially young people, using chat and text. So only about 24% of those were answered. 52% of texts in 2021 December. A year later, with 988 and with funding, 96% of chats, 99% of texts are being responded to. Calls, we saw an increase after a year of in terms of the number of calls that they were able to answer, and overall about a 91%, 91% as opposed to 64% of all contacts to the Lifeline have been answered. It varies by state. California, kind of look at this, the dark blue, very dark blue, are states that are answering 90 to 100% of their calls. The moderate blue is 80 to 89%. 22 states are answering about that number, and that's where California falls, is in that category, somewhere between close to 90%. And there are about 9 states that are answering between 70 and 79% of their calls. 7 states less than 70%. So the funding variabilities per state really can make a difference in terms of their responsiveness to those calls. Otherwise, they roll over to national backup centers and those calls do get answered. Just a note here, in California, the Miles Hall Lifeline and Suicide Prevention Act, many of you know, was legislation that was designed to enhance funding and supports for the crisis lines. And about some of you, I think, know the story about Miles Hall, and he was an individual who had schizoaffective disorder in Marin County's parents had to call 911 on to help him get transported to the hospital on a few occasions, and were very concerned about the police response, and actually worked with the police to say, please make sure that if you come out here, that to know Miles is not going to be a harm to you or anyone. He just needs help, and let's treat him accordingly. They tried to do everything they could to keep him safe, but the public safety response failed them and failed us yet again. In this case, he was killed. So here we are again in Miles' name here in California, and in the name of so many other people who've been lost to suicide, trying to make this a public health response. And I do want to say that I mentioned before about the transformation from Dr. Richard McKeon, that it is something that is going to transform the psychiatric emergency crisis care system in ways we haven't seen before. But I also think, as it has changed me in my practice, I just wanted to be a psychologist. I wanted to be a mental health practitioner, but after I became engaged with crisis care, it changed the way I thought about and saw a lot of the work I was doing. And I do believe that that same thing is going to happen in the mental health care system, that we're going to be thinking a lot more about how to prevent suicide, just like I'm thinking in my private practice every day. We're going to think a lot more about what it takes to keep a person safe, that it's not just assessment, it's really about human contact. It's about what happened outside of Chad Vera's office. It's about listening and being there for people. It's about helping them feel like they belong and that they matter. That is what's going to help keep people safe. And it's a reminder that it doesn't just even have to be in the mental health care system that people are going to get care, that it actually can be in the community. And I believe that 988 is going to affect the way we see mental health in the communities as well, not just how we see suicide prevention and crisis care in the mental health care system. I believe it's going to affect the way we see mental health as an overall important thing to our health. Just like 911 transformed the medical care system, and the law enforcement system, and the fire department, we saw, yes, it increased the number of fire departments, the firefighters, the number of cops, the number of ambulances, the number of cop cars. We saw it increase the number of jails, prisons, hospitals, all of that. But we also saw it increase prevention in the community. We saw a lot more fire safety talks in the community and people learning about how they can prevent fires. We heard a lot more about how we can reduce heart disease by not just
Dr.
CPR.
Draper?
Yep.
We've got, I think, about 5 minutes
Yep.
left, and then we do have a couple of questions.
Yeah,
So,
I'll get to that in just a minute. But I just want to note that I do believe that, just like it created CPR and it created nutrition, education, and exercise, that we learned that we can do something to reduce heart disease, the #1 killer, by doing things differently in our lives. All of that started with people being aware that people are dying and these emergency services responding through 911 wasn't enough. And we asked ourselves, what can we do to actually prevent these things from happening? So I believe this transformation from 988, or from 911 to 988, is going to enhance overall public health and safety, but first and foremost by taking a public health approach. So we have time for just a couple of questions here.
the question comes, mobile crisis teams can be dispatched by a 911 operator or a currently existing suicide hotline just as easily as 988. What was the thinking around needing a separate 988 hotline? I think that was the discussion that we had today, but can you talk just a little bit about how this may be more advantageous than going through 911 for dispatch or through?
Yeah, I mean, two things. One, I mean, dispatch is really, 911 is about dispatch. And what was noted before is that if it goes through a crisis contact line, 70% of the time it can be resolved on the phone. That's not what's going to happen if it goes through 911. That's just a dispatch. So there's a lot more that can happen and should happen in the crisis care continuum by starting with a crisis contact center doing the triage as opposed to 911. It doesn't mean both shouldn't happen, but when you're talking about getting mental health care, the message should be, let's not take it to 911, which is associated with public safety. Let's take it to 988, which is associated with public health. And there's a lot of stigma historically related to 911. And I think it's going to that would scare a lot of people off from phoning because they're more likely to send a cop car in their mind than a mobile crisis team.
And the second question is just about what processes are in place to evaluate the benefits of the newer hotline, especially in relation to some of the costs. We do know that states are levying taxes or levying a fee to go ahead and fund these. What is kind of being done down the road to evaluate the effectiveness?
This is a really interesting time because it's a partnership very much between states and federal government. The federal government, has been funding evaluations and will continue to fund evaluations of 988 in the National Suicide Prevention Lifeline. But what you have now are states that are investing in it, and if states are investing in their local lines, they too are going to want to do their own data analyses. They're going to be accountable for those funds. So the quality improvement efforts are going to be shared by both national and local efforts. So you can expect that there's going to be a lot more quality improvement focused locally as well as nationally, and everybody's going to get in the game. Right now, the talk is access. Later, it's going to be quality.
Now, just to let people know, we are kind of doing a one of these types of sessions for the next 7-8 weeks. At this point, 8 total, a little bit different focus. The next one is going to be a little bit deeper dive in the how and a little bit more technical about how 988 call centers actually work. The 5 that we have after that are going to be meeting the actual 988 call centers throughout California, learning what makes them a little bit different, what their focus is, what their current challenges are, what the successes are, how to access them. And then we'll have a wrap up at the end of those 8 weeks. So stay tuned for all of that coming through. I'm not seeing another question come through. So Dr. Draper, appreciate your time today. Thanks.
We'll see you again soon.